What's up, YouTube? Alright guys, welcome back to the channel. Super excited to have a whole new series for us. I've been getting a lot of emails from people saying, hey, can you make videos again? Sure. And two, how do you think as a doctor? What's it like as an attending? You're half a decade into your attending life. What's it like? What do you do? And can you help us think from your perspective now for those of us that are in med school and training and residency, etc. So absolutely I can, and let's do it together. So let's just jump into straight cases and see what we can put together. So I actually spent a lot of time recently and I created this website, and it's mainly for you guys. It's called Open Diagnostics. We're using AI to learn, write notes, and go through cases. So yes, I did become moderately psychotic as a neurologist and learn how to code. Okay, that's fun. So let's kind of go into this together and see what you can do. So on this site that I made, it's very fun. It's called Open Diagnostics because it's open to you and you can learn how to do diagnostics. That's all doctoring is, how to think about diagnoses, how to work through charts. That's the doctor side of it, like how to do things. And of course, great bedside manner, being sweet, working with staff, etc. But the core thing you cannot be bad at is how to think in medical diagnostics. For those of you who watched House MD, he called himself a diagnostician. That's not like a thing, but in TV it is, but it emphasizes the importance of diagnostics. So here we have like an AI diagnostics tool. I don't know anybody else on the internet that has this. We do, because we made it. And here you can just put in cases that you see in real life or when you're rounding as a med student or a resident, and it will help you figure out what to do next, what are the things to ask, and give you a pretty strong summary. So how to think like a doctor is right here. I was eat, breathing, and sleeping misery to create this because once I figured out how to think as a third year going into fourth year med student, my life changed. We've talked about this in prior videos. Now you have an AI tool to help you. You're not dependent upon your senior resident. You're not dependent upon your attending solely. Now you have AI. It exists. It's pretty cool. It can help you think like I do. We have a note writer for those of you in third and fourth year and obviously in residency. This will help you write your notes. Put in whatever you want. It'll make it a proper note. Relax. Now, let's do cases because that's what life's all about. Let's have fun. So let's do neuro because why not? All right. So let's just do this one. And then we'll do a bunch. But again, the purpose of these is for you to walk through them with me. Let's talk about neuro or any other specialty. We'll have other people help, but it's going to be fun. So whenever we're doing a case question on USMLE, on formal board exams, so I took neuro boards and vascular neuro boards, they're all the same. Everything is USMLE style. It never changes. So per always read the question and answers first. Don't jump into the big paragraph. So here we have, what is the most appropriate next step in the evaluation of this patient? LP, non-con CT head, CTA, MRI brain. So already they're saying, what diagnostics do you want? So no problem. Let's read the case. And I'll show you how to select. So in real life, when you're on your EMR or on USMLE tests, everything is obviously digital now. I do select to try to emphasize points to myself. Try it. It'll work. So, 46-year-old woman comes into the ED by her husband because she has sudden severe headache that began 30 minutes ago. So here, acute onset headache. She describes it as worst headache of her life. And she has some nausea, vomiting, and photophobia. So what does this mean? You have a young person, 46 is young. Many people are under 46 watching this probably. And she's coming in for acute onset headache. So acute onset headache, not subacute, not chronic. It's acute, it's a red flag. Worst headache of her life. You're already thinking subarachnoid hemorrhage. If you're not, let me tell you, you should be thinking subarachnoid hemorrhage. And this is classic. And I'll tell you, as a guy who happens to be vascular boarded, I see a tremendous amount of subarachnoid hemorrhage. People actually do say worst headache of my life. So yes, it's a buzzword, but yes, it's also clinically relevant. And again, this is the associated symptoms with meningeal signs and hemorrhage. You can have nausea, vomiting, and photophobia. But then they say no prior similar episodes, which is good because could it be like a weird migraine presentation? No trauma, that's good. No fever, meningitis, I guess, or recent illness. Good to know. Now, okay, so now it's going to be social history. So she has a 15-pack year smoking history, poorly controlled hypertension. Medications include hydrochlorothiazide, but she doesn't really take it. So under social history, why are they telling us this? Vascular risk factors. You have to know this. Not just for this case, but any case. Smoking increases risk for heart attack, stroke, and vascular disease. Poorly controlled hypertension increases risk for vascular disease. And she doesn't take her meds, so Essentially, her hypertension is not controlled. Okay, now it says family history is notable for her father dying of kidney problems in his 50s. Dying from renal disease, okay, could it be end stage renal and hemodialysis? Maybe. But again, rethinking subarachnoid hemorrhage, what is this? Probably polycystic kidney disease. And again, dying from it, it's reasonable. You may be wondering, why didn't they say polycystic kidney disease? Nobody in real life does. Patients just know dad had a kidney problem. Like, unless they're a doctor or very healthcare oriented, this is the real life way you hear things. It's not very elegant. And then the patient drinks alcohol but denies drug use on exam. She's in obvious distress, lying still, eyes closed. Well, you have a headache. BP's elevated, heart rate, respiratory, nothing's too impressive. SP's fine, but she's awake. There's nuchal rigidity with a positive Kernig, so that's meningeal signs. If you don't know what a Kernig is, also Brzezinski, YouTube these. You're on YouTube now. YouTube, Kernigs and Brzezinski. You need to learn these. They're very simple. It's this and bending the knee to the chin, or to the chest, excuse me, and chin to chest. Very simple, classic meningeal signs. No papilledema seen. So this is important. This is actually much more elevated and graceful. So if you look into the eye with your scope, papilledema is an indirect marker of elevated intracranial pressure. So a patient, let's just say in a different case, had a large hemorrhage and ICP is going up, she's drowsy with a headache, yeah, you can definitely have papilledema. But that is like also a very good exam. In real life, you run straight to CT. Not many people are looking in the eye. If you are, I mean, hats off to you. You're an amazing doctor. Do I do it? No. Do I want to do it? Absolutely. But what's the reality? The patient comes in already in CT, then the ED calls you. But, you know, they got to give you data. Cranial nerves are intact. Motor is good. Sensations intact. Reflexes are symmetric. No rash. Wonderful. So, again, if we think it's subarachnoid hemorrhage, are we going to go straight to LP? No. It's CT head. Make sure to bleed. Or is it a subdural? Or is it an intracranial? CTA, you're going to want that afterwards to look for an aneurysm, but not the first one. This is like they trick you with these little nuances. MRI, no. That's slow. That's, at this point, not even that valuable. So got to be CT head. Okay, we're in exam mode, not tutor mode, so won't tell us the answer. All right, CT head is performed within 45 minutes of onset. There's no hemorrhage. Why is this important? That can happen. This is called sentinel bleed. Sentinel bleed isn't a phrase that's used very commonly unless you're very subspecialty fellowship trained, I guess, or very within neuro. But very early CT can miss it. So that sentinel bleed or the subarach just started if it's small, or if it's perimesencephalic, but that again is very subcategory to vascular fellowship. Don't worry about that. It can miss. So what do you do? Discharge? No way, Jose. We have someone coming in with red flag headache syndromes, concern for subarach. Can't do that. Perform an LP? Absolutely. So if CT head is negative, strong clinical suspicion for subarach, next step, get an LP. This, what I just did with my hands, is called diagnostic reasoning. Okay, if you put this case in the AI diagnostics up here, it would teach you this, but you have to think like this in real life. Migraine therapy? No, we think it's a subarach. EEG, it didn't look like seizure. So let's get the LP to rule out sentinel bleed. LP shows a bunch of blood in all the tubes, probably subarach, or it could be a very traumatic tap, but that's really high. And yellow discoloration after centrifuge. So xanther, you have to know this. You get this, so you put the needle in, you get the CSF, it's in there, it looks bloody. You spin it in a centrifuge, and then it settles. The top layer of serum should be clear. If it's yellow, that is the xanthochromia, the blood breakdown of the red blood cells in the CSF. So what underlying condition most strongly predisposes this patient? So this is what we were talking about. Her father having renal disease is polycystic kidney disease. The mnemonic that I use is it's polycystic, so imagine like a cyst lesion, and then an aneurysm is classic for subarach, like kind of like a cyst, the aneurysm coming out. It's a good memory. Marfan and NF1 can cause other connective tissue disorders, but polycystic kidney disease is like the key one. All right. Which cerebral vessel is the most common location for an aneurysm? Okay, I don't know why the boards want you to know this. I don't know why we get asked this question on rounds. I just know it because I was told to memorize it, and I did. It's not Basler, it's not MCA, it's not pica. It's for some reason anterior communicating and anterior cerebral artery. So anterior circulation mainly at the junction and the circle of Willis. Why is that important? Someone in the comments, if you know why we are memorizing this, please tell me. I'm just memorizing it. but I don't know why. All right, so following again, sharing my real thoughts with you so you know how we think as the attending side. Following confirmation of diagnosis, which medication should be initiated to reduce the risk of delayed cerebral ischemia is nimodipine. So, because again, this is just classic. So classic in subarach is you have subarachnoid hemorrhage, you can have delayed cerebral ischemia through vasoconstriction, and nimodipine is the drug of choice. It's a very classic study you can look up that says that mannitol is for elevated intracranial pressure. Remember, the patient has no papilledema, so not an issue. Keppra is for seizure. We don't see seizures. Steroids. Giving steroids would be good if we had like a tumor or an infection that had a bunch of edema around it to control the edema, but CT head didn't mention edema, so it should be nimodipine. Okay, next, in addition to nimodipine, okay, so if this was like a multi-step question on boards, they would not let you go back, but to let you know it was nimodipine. Blood pressure should be carefully controlled to limit the risk of rebleeding. Which agent's most commonly used? So there's two ways to figure this out. One, you could just know it's nicardipine and cardine. Two, it's a continuous. We would never give an oral agent in the ICU with a brain bleed. Like, that's not controllable. How long is it going to take? Always IV. IV nitroprusside and propranolol you could use, but you really want the infusion to be able to titrate carefully to hit your blood pressure goal. Blood pressure goal is going to be less than 140 for these bleeds because it says subarach. So it's going to be the infusion. All right, which of the following, this is the key. Which definitive intervention should be pursued within 24 hours to secure the ruptured aneurysm and prevent rebleeding? This little word definitive changes everything. What's the cure? What's the actual thing? And the answer is embolization, oil, or clipping. They could have put either one here. They're not going to ask you clip or coil. That is subspecialty neurosurgery interventional question. That's 4 fellowships deep, not for you guys, don't worry. They won't even ask me that. So that's for the IR guys who are neurosurgeons and girls. So EBD, you could put an EBD. Let's say there's blood going into the ventricles causing hydrocephalus, and EBD put in would release the pressure until you can get to the OR to do a coil embolization or a clipping. But that's not going to be very common. I mean, that's a temporizing measure you can do to get to the OR, but that's not a definitive intervention. Serial lumbar punctures, I don't even know why you would do that. Maybe if someone has like high ICP and you're treating like pseudotumor, but that's now called IIH. Pseudotumor is an old name. We would not do that. Decompressive hemi. If you have a large bleed and it's causing herniation and you meet criteria for it, you can do a decompressive hemi. But again, coiling or clipping is the definitive treatment to secure the aneurysm and stop bleeding. All right, last question. 5 days after admission, the patient becomes confused and develops right-sided weakness. CT is no hemorrhage. You always get a CT whenever you have an acute change in exam, so it's not a hemorrhage. What's the most likely cause? Okay, so this is very classic. The whole reason we gave nimodipine was to prevent what we call delayed cerebral vasospasm causing an ischemic stroke. So this is really unfortunate. You could have a hemorrhagic stroke of a subarachnoid hemorrhage, and then about 3 to 14 days later, you could have cerebral vasospasm causing then an ischemic stroke. Like, that's not great. That's why subarach is in the ICU for always 14 days, to be there in the window of cerebral vasospasm. So rebleeding of the aneurysm, no, unlikely, because they said CT showed no hemorrhage. Hyponatremia can cause drowsiness or change in mental status, but it shouldn't cause lateralizing right-sided weakness. And subdural, again, they said no blood, and it would be kind of odd to get a subdural with bridging veins. That's the pathophysiology of the subdural. That would be odd. Okay, let's see how we did. Not bad, not bad. Again, biased here a little bit. You are going to ask a vascular guides question. So again, let's just kind of go through these because I think it's fun. But again, these details and explanations are where you grow. If you get the question right, don't just be like, I got it right, I'm a genius, next. Live in the answers. That's where all the learning is, man. Obviously, I'm going through it so you're learning as you're going, but when you're doing it yourself, you're just kind of answering and going, read these explanations. This is like, if you're not watching a video with me, read the explanations, please. Okay, so what's the most appropriate next step? Get a CT head non-con, because again, initial scan for bleed always is a non-con. It's very sensitive, and an LP only if it's non-diagnostic CT. Then we get the angio and MRI, just like we were saying. And again, the CT showed no hemorrhage. What to do? Again, if clinical suspicion is high and CT is negative, you get an LP to look for xanthochromia, or these persistent red blood cells, like we said. You don't discharge. That'd be nuts. All right, LP showed blood and the xanthochromia. And what was the predisposing factor? Like we said, it was the autosomal dominant polycystic kidney disease, because that's the classic association. Here they're also mentioning connective tissues are associated, because that can cause a lot of connective tissue disorders always cause a vascular risk, but for subarach, polycystic kidney is the key connection. What's the most common vessel? We got this right. So 30 to 40% are in the anterior communicating artery and anterior cerebral artery junction. Again, I don't know why we need to memorize this. When you have a bleed come in on the dry scan, you can kind of see where the blood is. And on angio, you're looking at all the vessels in the circle of Willis anyways. But again, if you know why this is important, please tell me down below. I would love to know. It would make me sleep better at night that I'm not just constantly memorizing stuff all the time. All right, following confirmation, again, what drug are we going to give to reduce the risk of delayed cerebral ischemia? Isn't that weird? You had a hemorrhagic subarach and now your risk is delayed ischemic? Tough case. So nimodipine, again, oral calcium channel blocker is given to prevent this vasospasm. You have to know that. That's classic. In addition to nimodipine, what else are we going to give? Again, we want titratable in the ICU. Everything in the unit has to be usually a drip or IV push, but drip is superior always. To have steady blood pressure, not going up and down like this with pushes. The up and down increases bleed risk. Have it nice and controlled. What's the definitive? Again, this is like a classic USMLE thing, or just in general, definitive treatment. And again, here, like we said, quill embolization or surgical clipping to obliterate the aneurysm lumen and then secure it. EVD is for hydrocephalus, like we talked about, but it's not definitive, and the other ones don't make sense. 5 days after admission, they're confused. Again, that's the vasospasm, and this is the key. 3 to 14 days. People will often ask you, patient comes in, they have a bleed. Families will ask you, how long will they be here? At least 2 weeks. Why? Because that's the window for the delayed cerebral vasospasm that will cause ischemia. So we have to be careful. And again, any acute change in exam gets stat CT head. Okay, let's go through our teaching pearls here. Again, subarach, thunderclap headache, worst headache of my life. Patients actually say that. Usually caused by a saccular aneurysm that ruptures. And again, it's the branch points. That's where the weakness is. And then risk factors, like we said, are all the vascular risk factors. Blood pressure, smoking, polycystic kidney, connective tissue, and here we wrote cocaine use, but that's just all amphetamines or stimulants. It's like a chemical hypertension you cause for yourself. Okay, diagnostic algorithm. This is what you need to learn. Like, you cannot mess this up as a trainee or a real doctor. This is what the AI diagnostics, if you put a subarachnoid case in there, you will get this. So again, non-contrast CT, first rule out blood. If it's high, get an LP, look for xanthochromia. If that's normal, get vessel imaging, look for the aneurysm once it's confirmed. Right? You have to know this pathway. This is how we think. You have to get it down. This is how you become an efficient doctor on a diagnostic side. Doesn't mean you're sweet and loving at the bedside. You got to do all of it, but you got to be good at this. Again, management, secure it, clip and coil, give nimodipine, control blood pressure. Like we said, goal is less than 140, and then treat the hydrocephalus if you have it. Usually it's an IVH case. You would call neurosurgery for the EVD. And again, high yield complications, rebleeding. It's the most common cause of death. Vasospasm, you have to know this. You have to know this. They're crazy about it because it's the highest risk. How do you diagnose it clinically? Okay, this is like much more advanced. You do daily transcranial Dopplers. That's like ultrasound here and it's also in the back and also like through the eye to look for cerebral vasospasm of blood moving through blood vessels in the circle of Willis, and you're looking at velocities. That's very subspecialized. Just know transcranial Doppler is a thing, and you can use it to assess vasospasm. You don't need to know anything more than that. Anything more, fellowship will teach you, and you can even learn how to read them and write the reports like we do. Hyponatremia, again, SIADH or cerebral salt wasting, that would cause electrolyte abnormality. And again, differentials, and then the key buzzwords you have to know. Okay, I hope you guys enjoyed this case. I hope you enjoyed using our first case study in open diagnostics. And again, you can go through these, because even if we were to take, say, this and put it in AI diagnostics, I wonder what it would say. It would run you through the differential for you to try to practice going through diagnostics. So you can do this, go through it, learn how to think like a doctor, learn the misery of what I learned the hard way. with AI now, and it'll walk you through it saying yes or no questions. It'll teach you clinical reasoning. Go do it, have fun, learn. I hope you guys enjoyed this video. I hope you're having fun in medicine. I'm 5 years out going into year 6, and I'm having a blast. And now I made something silly and fun, but it's serious, where you guys can learn too. All right, guys, as always, enjoy your studies.